So now we look at defining a case. Before counting cases, the epidemiologists must decide what to count, that is, what to call a case. For that, the epidemiologist uses a case definition. A case definition is a set of standard criteria for classifying whether a person has a particular disease, syndrome, or other health condition. Some case definitions, particularly those used for national surveillance, have been developed and adopted as national standards that ensure comparability. Use of an agreed upon standard case definition ensures that every case is equivalent regardless of when or where it occurred or who identified it. Furthermore, the number of cases or rate of disease identified in one time or place can be compared with the number or rate from another time or place. For example, with a standard case definition, health officials could compare the number of cases of gonorrhea that occurred in Bannock County, Southeast Idaho, in 2023 with the number that occurred there in 2024. Or they could compare the rates in 2024 with the national rates in that same year. So when everyone uses the same standard case definition and the difference is observed, the difference is likely to be real rather than the result of variation in how cases are classified. So to ensure that all health departments in the United States use the same case definitions for surveillance, the Council of State and Territorial Epidemiologists, CSTE, the CDC, and other interested parties have adopted standard case definitions for the identifiable infectious diseases. These definitions are revised as needed. In 1999, to address the need for common definitions and methods for state-level chronic disease surveillance, CSTE, the Association of State and Territorial Chronic Disease Program Directors, and the CDC adopted standard definitions for 73 chronic disease indicators. Other case definitions, particularly those used in local outbreak investigations, are often tailored to the local situation. For example, a case definition developed for an outbreak of viral illness might require laboratory confirmation and where such laboratory services are available, but likely would not if such services were not readily available, as we would see in rural or underserved areas. So a case definition consists of clinical criteria and sometimes limitations on time, place, and person. The clinical criteria usually include confirmatory laboratory tests, if available, or combinations of symptoms, signs, and other findings. Case definitions used during outbreak investigations are more likely to specify limits on time, place, and or person than those used for surveillance. And so many case definitions require laboratory confirmation, and however, this is not always necessary. In fact, some diseases have no distinctive laboratory findings. Kawasaki syndrome, for example, is a childhood illness with fever and rash that has no known cause and no specifically distinctive laboratory findings. Its case definition is based on the presence of fever, at least four or five specified clinical findings, and the lack of a more reasonable explanation. And so a case definition may have several sets of criteria depending on how certain the diagnosis is. For example, during an investigation of a possible case or outbreak of measles, a person with a fever and a rash might be classified as being suspected, probable, or a confirmed case of measles, depending on what evidence for measles is present. A case might be classified as suspected or probable while waiting for the laboratory results to become available. And then once the laboratory provides the reports, the case can be reclassified as either confirmed or not a case, depending on the results. So, in the midst of a large outbreak of a disease caused by a known agent, some cases may be permanently classified as suspected or probable because officials may feel that running laboratory tests on every patient with a consistent clinical picture and a history of exposure, um, for example, in chickenpox, is unnecessary and even wasteful. So case definitions should not rely on laboratory culture results alone, since organisms are sometimes present and without causing disease. Case definitions can also change over time as more information is obtained. And the first case definition for the severe acute respiratory syndrome, SARS, based on clinical symptoms and either contact with a case or travel to an area with SARS transmission, was published in the CDC's Morbidity and Mortality Weekly Report on March 21st, 2003. And on March 29, after a novel coronavirus was determined to be the causative agent, an interim surveillance case definition was published that included laboratory criteria for evidence of infection with the SARS-associated coronavirus. And by June, the case definition had changed several more times. And subsequently, in anticipation of a new wave of cases in the next year, 2004, a revised and much more complex case definition was published in December 2003. So there can be variations in case definitions. Case definitions may also vary according to the purpose for classifying the occurrence of disease of a disease. For example, health officials need to know as soon as possible if anyone has symptoms of plague or anthrax, so that they can begin planning what actions to take. For such rare but potentially severe communicable diseases, for which it is important to identify every possible case, health officials use a sensitive case definition. So a sensitive case definition is one that is broad or loose, so to speak, in the hope of capturing most or all of the true cases. For example, the case definition for a suspected case of rubella is any generalized rash illness of acute onset. This definition is quite broad and will include not only all cases of rubella, but also measles, chickenpox, and rashes due to other causes such as drug allergies. So while the advantage of a sensitive case definition is that it includes most or all of the true cases, the disadvantage is that it sometimes includes other illnesses as well. On the other hand, an investigator studying the causes of a disease outbreak usually wants to be certain that any person included in a study really had the disease. So that investigator will prefer a specific or strict case definition. And for instance, in an outbreak of salmonella infection, the investigators would be more likely to identify the cause or the source of the infection if they included only persons who were confirmed to have been infected with that organism, rather than including anyone with just acute diarrhea, because some persons may have had diarrhea from a different cause. And in this setting, the only disadvantages of a strict case definition are the requirement that everyone with symptoms be tested and an underestimation of the total number of cases if some people with salmonellosis are not tested. So we look at concepts of disease occurrence. A critical premise of epidemiology is that disease and other health events do not occur randomly in a population, but are more likely to occur in some members of the population than others because of risk factors that may not be distributed randomly in the population. As noted earlier, one important use of epidemiology is to identify the factors that place some members of the population at greater risk than others. And a number of models of disease causation have been proposed. Among the simplest of these is the epidemiologic triad or triangle, the traditional model for infectious disease transmission. And the triad consists of an external agent, a susceptible host, and an environment that brings the host and the agent together. In this model, disease results from the interaction between the agent and the susceptible host in an environment that supports transmission of the agent from a source to that host. Two ways of depicting this model are shown here. The agent, the host, and environmental factors interrelate in a variety of complex ways to produce disease. And different diseases require different balances and interactions of these three components. Development of appropriate, practical, and effective public health measures to control or prevent disease usually requires assessment of all three components and their interactions. So the agents originally referred to an infectious microorganism or pathogen, a virus, bacterium, parasite, or other microbe. Generally, the agent must be present for disease to occur. However, presence of that agent alone is not always sufficient to cause disease. And a variety of factors influence whether exposure to an organism will result in disease, including the organism's pathogenicity, that is, its ability to cause disease, and the dose of the microbe that the host is exposed to. Over time, the concept of agents has been broadened to include chemical and physical causes of disease or injury. And these include chemical contaminants such as the L and tryptophan contaminant responsible for eosinophilia myalgial syndrome, as well as physical forces such as repetitive mechanical forces associated with carpal tunnel syndrome. While the epidemiology triad serves as a useful model for many diseases, it has proven inadequate for chronic diseases like cardiovascular disease, cancer, and the others that appear to have multiple contributing causes without a single necessary one. And the host refers to the human who can get the disease. A variety of factors intrinsic to the host, sometimes called risk factors, can influence an individual's exposure, susceptibility, or response to a causative agent. And the opportunities for exposure are often influenced by behaviors such as sexual practices, hygiene, and other personal choices, as well as by age and sex. So susceptibility and response to an agent are influenced by factors such as genetic composition, nutritional and immunologic status, anatomic structure, presence of disease or medications, and psychological makeup. The environment refers to extrinsic factors that affect the agent and the opportunity for exposure. So environmental factors include physical factors such as geology and climate, biologic factors such as insects that transmit the agent, and socioeconomic factors such as crowding, overcrowding, sanitation, and the availability of health services. So because the agent host environment model did not work well for many non-infectious diseases, several other models that attempt to account for the multifactorial nature of causation have been proposed. One such model was proposed by Rothman in 1976 and has come to be known as the causal pies. So this model is illustrated in the figure here. An individual factor that contributes to causing disease is shown as a piece of a pie. After all the pieces of a pie fall into place, the pie is complete and disease occurs. So the individual factors are called component causes. And the complete pie, which might be considered a causal pathway, is called a sufficient cause. And a disease may have more than one sufficient cause, with each sufficient cause being composed of several component causes that may or may not overlap. A component that appears in every pie or pathway is called a necessary cause, because without it, disease does not occur. And note in this figure that component cause A is a necessary cause because it appears in every pie. The component causes may include intrinsic host factors as well as the agent and the environmental factors of the agent-host environment triad. A single component cause is rarely a sufficient cause by itself, For example, even exposure to a highly infectious agent such as measles virus does not invariably result in measles disease. Host susceptibility and other host factors may also play a role. At the other extreme, an agent that is usually harmless in healthy persons may cause devastating disease under different conditions. And so pneumocystis jirovecii is an organism that harmlessly colonizes the respiratory tract of some healthy persons, but can cause potentially lethal pneumonia in persons whose immune systems have been weakened by human immunodeficiency virus (HIV). So the presence of this organism is therefore a necessary but not sufficient cause of pneumocystis pneumonia. In this figure, it would be represented by component cause A. So as the model indicates, a particular disease may result from a variety of different sufficient causes or pathways. For example, lung cancer may result from a sufficient cause that includes smoking as a component cause. Smoking is not a sufficient cause by itself, however, because not all smokers eventually develop lung cancer. And neither is smoking a necessary cause because a small fraction of lung cancer victims have never smoked. So suppose component cause B is smoking and component cause C is asbestos. Sufficient cause 1 includes both smoking and asbestos, and that's B and C. And sufficient cause 2 includes smoking without asbestos, and sufficient cause 3 includes asbestos without smoking. But because lung cancer can develop in persons who have never been exposed to either smoking or asbestos, a proper model for lung cancer would have to show at least one more sufficient cause pi that does not include either component B or component C. So note that public health action does not depend on the identification of every component cause. Disease prevention can be accomplished by blocking any single component of a sufficient cause, at least through that pathway. For example, elimination of smoking, which is component B, would prevent lung cancer from sufficient causes 1 and 2, although some lung cancer will still occur through sufficient cause 3. And so, as I've mentioned, the traditional epidemiologic triad model holds that infectious diseases result from the interaction of agent, host, and environment. More specifically, transmission occurs when the agent leaves its reservoir or host through a portal of exit and is conveyed by some mode of transmission and enters through an appropriate portal of entry to infect a susceptible host. Now, this sequence is called the chain of transmission. Now, let's look at each component now individually. A reservoir, human reservoirs may or may not show the effects of illness, and that leads us to what we call a carrier, who is a person with inapparent infection who is capable of transmitting the pathogen to others. Asymptomatic or passive or healthy carriers are those who never experience symptoms despite being infected. And incubatory carriers are those who can transmit the agent during the incubation period and before clinical illness or clinical signs and symptoms appear. Convalescent carriers are those who have recovered from their illness but remain capable of transmitting the pathogen to others. And chronic carriers are those who continue to harbor a pathogen such as hepatitis B or Salmonella typhi, the causative agent of typhoid fever, for months or even years after their initial infection. One notorious carrier is Mary Mallon, or Typhoid Mary as she's known in the public health world, who was an asymptomatic chronic carrier of Salmonella typhi. As a cook in New York City and New Jersey in the early 1900s, she unintentionally infected dozens of people until she was placed in isolation on an island in the East River, where she died 23 years later. So The reservoir of an infectious agent is the habitat in which the agent normally lives, grows, and multiplies. Reservoirs include humans, animals, and the environment. And the reservoir may or may not be the source for which an agent is transferred and from which an agent is transferred to a host. For example, the reservoir of Clostridium botulinum um, is soil, but the source of most botulism infections is improperly canned food containing the microbial spores of that organism. Um, so human reservoirs, and many common infectious diseases have human reservoirs. Diseases that are transmitted from person to person without intermediaries include the sexually transmitted diseases, measles, mumps, streptococcal infection, and many respiratory pathogens. So because humans were the only reservoir for the smallpox virus, naturally occurring smallpox was eradicated after the last human case was identified and isolated in 1970. Of course, the World Health Organization declared smallpox eradicated in 1980. So human reservoirs may or may not show the effects of illness. As we noted earlier, a carrier is a person with inapparent infection who is capable of transmitting the pathogen to others. And asymptomatic or passive or healthy carriers are those who never experience symptoms despite being infected. Incubatory carriers are those who can transmit the agent during the incubation period and before clinical illness begins. Convalescent carriers are those who have recovered from their illness but remain capable of transmitting to others. And chronic carriers are those who continue to harbor a pathogen such as hepatitis B virus or Salmonella typhi, the causative agent of typhoid fever. So carriers commonly transmit disease because they do not realize that they are infected and consequently take no special precaution to prevent transmission. Symptomatic persons who are aware of their illness, on the other hand, may be less likely to transmit infection because they are either too sick to be out and about, or they take precautions to reduce transmission, or they receive treatment that limits the disease. So let's look at animal reservoirs. Humans are also subject to diseases that have animal reservoirs. And many of these diseases are transmitted from animal to animal with humans as incidental hosts. And the term zoonosis refers to an infectious disease that is transmissible under natural conditions from vertebrate animals to humans. And long recognized zoonotic diseases include brucellosis, which is gotten from cows and pigs, anthrax from sheep, plague from rodents, trichinellosis and trichinosis from swine, tularemia from rabbits, rabies from bats, raccoons, dogs, and other mammals, and so on. So zoonosis may newly emergent in North America include West Nile encephalitis from birds and monkeypox. So many newly recognized infectious diseases in humans, including HIV/AIDS, Ebola infection, and SARS, are thought to have emerged from animal hosts, although those hosts have not yet been identified. Then we look at environmental reservoirs. Plants, soil, and water in the environment are also reservoirs for some infectious agents. And many fungal agents, such as those that cause histoplasmosis, they live and multiply in soil. Outbreaks of Legionnaire's disease are often traced to water supplies in cooling towers and evaporative condensers, which are reservoirs for the causative organism Legionella pneumophila. So next is the portal of exits, which is the path by which a pathogen leaves its host. And the portal of exit usually corresponds to the site where the pathogen is localized. And for example, influenza viruses and Mycobacterium tuberculosis exit the respiratory tract, schistosomes leave through the urine. Vibrio cholerae physis, and so on. Enterovirus 70, a cause of hemorrhagic conjunctivitis, lives through conjunctival secretions. So some blood-borne agents can exit by crossing the placenta from mother to fetus, like rubella, syphilis, and toxoplasmosis, while others exit through cuts or needles in the skin, like hepatitis B, or blood-sucking arthropods, like malaria. Move over to modes of transmission. An infectious agent may be transmitted from its natural reservoir to a susceptible host in different ways. There are different classifications for modes of transmission, and here we have one classification. So in indirect transmission, an infectious agent is transferred from a reservoir to a susceptible host by direct contact or droplet spread. And direct contact occurs through skin-to-skin contact, like kissing and sexual intercourse. And direct contact also refers to contact with soil or vegetation harboring infectious organisms. And thus, infectious mononucleosis, also known as kissing disease, and gonorrhea are spread from person to person by direct contact. Hookworm is spread by direct contact with contaminated soil. Droplet spread refers to spread with relatively large short-range aerosols produced by sneezing, coughing, or even talking. So droplet spread is classified as direct because transmission is by direct spray over a few feet and a short distance before the droplets fall to the ground. And pertussis and meningococcal infections are examples of diseases that are transmitted from an infectious patient to a susceptible host by droplet spread. Indirect transmission refers to the transfer of an infectious agent from a reservoir to a host by suspended air particles, inanimate objects, or animate intermediaries, like which we call vectors. Airborne transmission occurs when infectious agents are carried by dusts or droplet nuclei suspended in air. So droplet nuclei are the dried up residues of droplets, and then because they have become lighter, they are able to be carried in air for longer distances without settling down quickly like their parent droplets. So airborne dust includes material that has settled on surfaces and become resuspended by air currents, as well as infectious particles blown from the soil by the wind. So like I said before, droplet nuclei are dried residue of less than 5 microns in size, and in contrast to droplets that fall to the ground within a few feet, droplet nuclei may remain suspended in air for long periods of time and may be blown over great distances. So measles, for example, has occurred in children who came into a physician's office after a child with measles had left, and because the measles virus remained suspended in the air. Vehicles that may indirectly transmit an infectious agent include food, water, biological products like blood, and fomites, which are inanimate objects such as handkerchiefs, beddings, or surgical scalpels. A vehicle may passively carry a pathogen, as food on water may carry hepatitis A virus, and then alternatively, the vehicle may provide an environment in which the agent grows and multiplies or produces toxins, as improperly canned foods provide an environment that supports production of botulinum toxin by Clostridium botulinum norm. So vectors such as mosquitoes, fleas, and ticks may carry an infectious agent through purely mechanical means, or may support growth or changes in the agent. Examples of mechanical transmission are flies carrying Shigella on their appendages, and fleas carrying Yersinia pestis, the causative agent of plague, in their guts. In contrast, in biologic transmission, the causative agent of malaria or guinea worm disease undergo maturation in an intermediate host before it can be transmitted to humans. The portal of entry refers to the manner in which a pathogen enters a susceptible host, and the portal of entry must provide access to tissues in which the pathogen can multiply or its toxin can act. Often, infectious agents use the same portal to enter a new host that they use to exit the source host. For example, the influenza virus exits the respiratory tract of the source host and enters the respiratory tract of the new host. In contrast, many pathogens that cause gastroenteritis follow a so-called fecal-oral route, because they exit the source host in feces and are carried on inadequately washed hands to a vehicle such as food, water, or utensils, and enter a new host through the mouth. Other portals of entry include the skin, as in hookworm, mucous membranes, as for syphilis, and blood, as with hepatitis B, human immunodeficiency virus (HIV). So susceptibility of a host depends on genetic or constitutional factors, specific immunity, and non-specific factors that affect an individual's ability to resist infection or to limit the pathogenicity of the infectious agent. An individual's genetic makeup may either increase or decrease susceptibility. For example, persons with sickle cell traits seem to be at least partially protected from severe malaria. And specific immunity refers to protective antibodies that are directed against a specific agent. And such antibodies may develop in response to infection or receiving a vaccine or a toxoid, and which is a toxin that has been deactivated but retains its capacity to stimulate production of antibodies, or may be acquired by transplacental transfer from mother to fetus or by injection of antitoxin or immune globulin. Non-specific factors that defend against infection include the skin, the mucous membranes, gastric acidity, cilia in the respiratory tract, the cough reflex, and non-specific immune responses like inflammation. So factors that may increase susceptibility to infection by disrupting host defenses include malnutrition, alcoholism, and disease or therapy that impairs non-specific immune response, like cancer chemotherapy. So, what are the implications of the chain of transmission for public health? Knowledge of the portals of exit and entry and the modes of transmission provides a basis for determining appropriate control measures. So, in general, control measures are usually directed against the segments in the infection chain that is most susceptible to intervention, unless practical issues dictate otherwise. For some diseases, the most appropriate intervention may be directed at controlling or eliminating the agent at its source. A patient sick with a communicable disease may be treated with antibiotics or to eliminate the infection. And an asymptomatic but infected person may be treated both to clear the infection and to reduce the risk of transmission to others. In the community, soil may be decontaminated or covered to prevent escape of the agent. Some interventions are directed at the mode of transmission. So interruption of direct transmission may be accomplished by isolation of someone with infection or counseling persons to avoid the specific type of contact associated with transmission. And vehicle-borne transmission may be interrupted by elimination or decontamination of the vehicle. And to prevent fecal-oral transmission, efforts often focus on rearranging the environment to reduce the risk of contamination in the future and on changing behavior such as promoting hand washing. For airborne diseases, strategies may be directed at modifying ventilation or air pressure and filtering or treating the air. And to interrupt vector-borne transmission, measures may be directed towards controlling the vector population, such as spraying to reduce the mosquito population. And some strategies that protect portals of entry are simple and effective. For example, bed nets are used to protect sleeping persons from being bitten by mosquitoes that may transmit malaria. A dentist face mask and gloves are intended to protect the dentist from a patient's blood, secretions, and droplets, as well as to protect the patient from the dentist. Wearing of long pants and sleeves and use of insect repellents are recommended to reduce the risk of Lyme disease and West Nile virus infection, which are transmitted by the bite of ticks and the mosquitoes, respectively. Some interventions aim to increase the host defenses, and vaccinations promote development of specific antibodies that protect against infection. On the other hand, prophylactic use of anti-malarial drugs recommended for visitors to malaria endemic areas does not prevent exposure through mosquito bites, but does prevent infection from taking roots in the host. Finally, some interventions attempt to prevent a pathogen from encountering a susceptible host. The concept of herd immunity suggests that if a high enough proportion of individuals in the population are resistant to an agent, then those few who are susceptible will be protected by the resistant majority, since the pathogen will be unlikely to find those few susceptible individuals, in quote. And so the degree of herd immunity necessary to prevent or interrupt an outbreak varies by disease. And in theory, herd immunity means that not everyone in a community needs to be resistant or immune to prevent disease spread and occurrence of an outbreak. So in practice, herd immunity has not prevented outbreaks of measles and rubella in populations with immunization levels as high as 85 to 90%. And one problem is that in highly immunized populations, the relatively few susceptible persons are often clustered in subgroups and defined by socioeconomic or cultural factors. And if the pathogen is introduced into one of these subgroups, an outbreak may occur. So let's look at the occurrence of epidemics. And the amount of a particular disease that is usually present in a community is referred to as the baseline or endemic level of the disease. And this level is not necessarily the desired level, which may in fact be zero, but rather is the observed level. In the absence of intervention and assuming that the level is not high enough to deplete the pool of susceptible persons, the disease may continue to occur at this level indefinitely. Thus, the baseline level is often regarded as the expected level of the disease. And while some diseases are so rare in a given population that a single case warrants an epidemiologic investigation, for example, rabies, and plague, and polio, other diseases occur more commonly, so that only deviations from the normal and from the norm will warrant investigation. Sporadic refers to a disease that occurs infrequently and irregularly. And endemic refers to the constant presence and or usual prevalence of a disease or infectious agent in a population within a geographic area. And hyperendemic refers to persistent high levels of disease occurrence. So when a disease is endemic and at very high levels, you say it is hyperendemic. Occasionally, the amount of disease in the community rises above the expected level, and so an epidemic refers to an increase, often sudden, in the number of cases of a disease above what is normally expected in that population and in that area at that time. So outbreak carries the same definition of epidemic, but is often used for a more limited geographic area and sometimes to avoid public panic. Um, Cluster refers to an aggregation of cases grouped in place and time that are suspected to be greater than the number expected even though the expected number may not be known. And a pandemic refers to an epidemic that has spread over several countries or continents, and usually affecting a large number of people. So epidemics occur when an agent and susceptible host are present in adequate numbers, and the agent can be effectively conveyed from a source to the susceptible hosts. More specifically, an epidemic may result from a recent increase in amount of virulence of the agent, the recent introduction of the agent into a setting where it has not been before, an enhanced mode of transmission so that more susceptible persons are exposed, a change in the susceptibility of the host response to the agent, and or factors that increase host exposure or involve introduction through new portals of entry. So this description of epidemics presumes only infectious agents, but there can also be epidemics of non-infectious diseases. For example, diabetes and obesity exist in epidemic proportions in the United States. And we will talk more about epidemics and the types of epidemics and when we treat field epidemiology later in the course. Thank you.